Assalamu alaikum. I'm Dr. Naha Qasim. I'm here today with you to discuss a major aspect of the physical well-being of individuals. I mean the preventive care. So this is a very important health topic that concerns every branch in medicine and includes not only disease prevention. So when we are talking about prevention, we also are talking about preventing complications from chronic diseases and early screening of these complications, good control of these chronic conditions, part of the prevention, preventing the iatrogenic harm that we can unintentionally affect our patients with over medicalizations or over treatment. Also, when we are talking about disease prevention, we are talking about wide varieties of interventions, including promoting a healthy lifestyle from the beginning, giving certain vaccinations to prevent certain infectious diseases. It can be also in the form of operations, certain interventions, surgeries, or medications that can be given as part of the prevention, as we will see. So let's start with our discussion. Now, we are discussing clinical scenarios together to show how to implement the clinical practice guidelines into clinical practice. But for more details, please download the complete lecture from tiny.cc prevention or from the Moodle interface of the Hashemite University. Prevention is very important. عنا بالعربي مثل كتير مهم نحكي فيه درهم وقاية خير من قنطار علاج. Just to remember from the history, smallpox eradication was accomplished by prevention rather than cure. A lot of diseases are prevented and complications from infectious diseases are prevented by vaccination. This is a very important example of the importance of prevention. Also, cancer is probably preventable disease. للأسف, nowadays the major focus is on the curative treatments, medications, rather than the preventive strategies to prevent this lethal condition. In this picture, we can see several doctors who are walking. Some of them are walking confidently, like this doctor, and some of them are about to fall down. This is an example of how how implementing guidelines in our clinical practice will help us be safer doctors, be confident that we are giving our patients good practice, from the best evidence, and the most important thing is always to check the evidence-based medicine to know where we are in this service that we are providing to our patients. This is the famous triangle of evidence, and we have here the meta-analysis of systematic reviews, which provide the best evidence, the strongest evidence from which guidelines usually extract their recommendations and statements. Now, according to the Institute of Medicine, it defines the guidelines as statements of recommendations that are intended to optimize the patient care. هلا من وين جايين هدول recommendations? They are informed by systematic reviews of evidence and by assessment of magnitude of benefits and harms of alternative options. So we have these always to keep this balance in our minds when we are planning to provide our patient with any service. So always there are benefits and always there are harms from any service that we are going to provide for our patient. Please keep in mind this balance. If we are having a great net benefit, we will go with this service. Otherwise, we have to think and think again. Now, in our talk today, we are focusing about the recommendations from the United States Preventive Services Task Force guidelines. And as any guidelines, we have grades for the evidence. When we are talking about A and B recommendations, we are talking about services with net benefit, good net benefit, either great net benefit or moderate net benefit. When we are talking about C recommendations, we are talking about small net benefits. So this service has to be selected for certain individuals or recommended for selected individuals based on their conditions, comorbidities, and preferences as well. When we are talking about D recommendations, there is harm or no net benefit from that service, so this service is not recommended, is discouraged. When we are talking about the presence of insufficient evidence on that service, we have to have further studies to reclassify this service as one of these four recommendations or four statements. So A recommendation, there is high certainty that the net benefit is great. B recommendation, there is high certainty that the net benefit is moderate, or moderate certainty that the net benefit is great. And C recommendation, there is small net benefits. D recommendation, either the benefits and harms are equal, or there is net harm. The harm outweigh the benefit. Now, when we are thinking about a preventive service, to implement it or not at the national level or at the community level, we are looking for different criteria. So what are these criteria? Number one, how much burden of suffering from that condition in terms of the 6 Ds. So how much there is utilization of medical services, how much there is the frequency of this disease, how much mortality from this disease, how much disability from this disease, and so on. So this is one of the criteria, the burden of suffering. The other criteria is the screening test, the available screening test. Is there available, affordable, effective screening test, cost effective, and very importantly, is that screening test would be safe? This is very important aspect, because when we are talking about preventive services, we are talking about apparently healthy individuals. They are not suffering. Unlike patients who are suffering and having symptoms and seeking medical attention for these symptoms, so they are expecting some or they can tolerate some harms from these diagnostic tests that you are doing for them. Unlike patients who are apparently healthy, that don't have suffering, they don't complain from symptoms, so they will not accept harms from these screening tests, for example. So the screening test has to be especially safe. This is very important. And effective in terms of specificity and sensitivity. Why sensitivity? Because we are doing a screening test on healthy individuals or apparently healthy individuals, so we are expecting the number of individuals who will turn out to be positive small. So we don't have to, we don't want to have negative or false negative results. So if the sensitivity is not that much high with a lot of false negative results, it will not serve us a lot. So it has to be sensitive. And specificity also, we are tending for small false positive results. Why? Because if we have a positive test, we have to have a confirmative diagnostic test, and some of them can be invasive and harmful to the patient. So we have to have this screening test also specific as much as possible. And the third criteria that we have to think about is the treatment options, the available treatment options. Are they safe, effective, cost effective? And very importantly, if the treatment early will alter the outcome of the patient, it will be more effective than if later treatment was implemented without screening. And this is very important aspect. Now let's start with our first scenario. A 48-year-old patient presented to the clinic for the first time for a simple common reason, upper respiratory tract infection. Now some clinical reminder systems in like برنامج حكيم الموجود عندنا بالأردن بوزارة الصحة has allowed you to screen him for cardiovascular disease. So what would you do? How to screen our patients for cardiovascular disease? This is very important. Now, any individual came to the clinic from the age of 20 and above, we have to screen him for cardiovascular disease. How to screen for cardiovascular disease? We have three aspects to look for. Number one, by history, we have to ask about risk factors for cardiovascular disease. Number two, we have to check for the fasting lipid profile. And number three, for individuals 40 and above, we have objective calculators to calculate the 10-year cardiovascular risk. So how to screen for cardiovascular disease? By these three measures. By having a fasting lipid profile, by asking the patient about the risk factors for cardiovascular disease, history of diabetes, history of hypertension, physical inactivity, obesity, presence of family history of cardiovascular disease or sudden death before the age of 55. If we are talking about first degree male relative, and below the age of 65 if we are talking about first degree female relative. These are the risk factors and the objective calculators we have talked about. These calculators are very important to predict the 10-year cardiovascular risk, so that we can, if we found that our patient to have moderate to high risk for the cardiovascular disease, we have to implement certain strategies to lower his risk of cardiovascular disease. Now, by history, the patient is not known to be diabetic or hypertensive. Is it indicated at this time point to check for his blood sugar and blood pressure? So the question is, when we have to screen for the diabetes, when we have to screen for hypertension. Now, for hypertension, every individual has to be screened by blood pressure measurement at least annually, starting from the age of 18. If we are talking about adults, and if we are talking about pediatrics, also any child has to be screened for hypertension beginning from the age of 3. So collectively, any individual from the age of 3 and above have to be screened for hypertension. So yes, it's indicated that this patient has to be screened for hypertension. And for diabetes, what about diabetes? According to the USPSTF, any individual at the age of 40 and above with body mass index above 25, so with overweight or obesity, has to be screened for diabetes. And for the American Diabetic Association, it's recommended that any adult with body mass index above 25 plus additional risk factor for diabetes has to be screened for diabetes regardless of his age. And if there is no risk factor for diabetes, screening should be started at the age of 45 years. So we have to screen our patients from the age of 40 or 45 years according to the guidelines we implement, and to repeat the test every 3 years. If it is negative, أكيد, we have to repeat it every 3 years. What test we have to do? Either the fasting blood sugar, the oral glucose tolerance test, or the hemoglobin A1C. All are options. So it is indicated to screen our patient for both hypertension and diabetes. He is 48 years old. According to the American Diabetes Association, it's indicated any individual without risk factors to start screening at the age of 45. And if there is a risk factor, any risk factor plus overweight has to be screened at any age. And the test should be repeated every 3 years if it was negative. And for the hypertension, yes, every individual 3 years and above has to be screened for hypertension at least annually. Now, when to start screening your patient for dyslipidemia, and how frequently would you repeat the test? Now, for dyslipidemia, we have a lot of guidelines. According to the USPSTF, any individual 40 and above should be screened by fasting lipid profile. Other guidelines state that every individual, starting from the childhood, there has to be universal screening for dyslipidemia at the age of 9 to 11 years, then another screening at the age of 17 to 21 years, and this goes with what we have mentioned previously about the screening for cardiovascular disease that has to be as part of this screening to include the fasting lipid profile. And remember that we have mentioned that screening for the cardiovascular disease has to begin from the age of 20 and every 3 to 5 years. So at the age of 17 to 21 years, we have to have another fasting lipid profile. Then when to start regularly, this depends on if the patient has the risk for cardiovascular disease, high risk for cardiovascular disease or not, and if he is female or male. So if the patient has high risk for cardiovascular disease, male, start screening him at the age of 25 to 30. And if the female has high risk for cardiovascular disease, start screening her from the age of 30 to 35. If there is no risk factors for cardiovascular disease, if there are no risk factors for cardiovascular disease, start screening males at the age of 35 and females at the age of 45 regularly every 3 to 5 years. If the test is substantially below the threshold for screening, you can repeat the test every 5 years. However, if it is at around the threshold, al-hiffa, you have to repeat the screening every 3 years. So, screening for dyslipidemia, to summarize, according to the SPSTF, there should be screening for every individual at the age of 40 and above by fasting lipid profile. And if we have to implement more detailed recommendations, we can screen our patient as universal screening without risk factors for healthy individuals at the age of 9 to 11 years, adolescents, then 17 to 21 years. This reading will help us in starting our cardiovascular disease risk assessment. Then, regular screening depends on the gender and the risk for cardiovascular disease. Our patient tells you that many of his friends are taking aspirin and lipid-lowering agents and wonders if he could benefit from these drugs. This is a common question from our patients. Am I a candidate for taking aspirin or statin to lower my cardiovascular risk? This is a common question. The answer is, this depends on his cardiovascular disease risk, whether he has high or low risk for cardiovascular disease, and this has to be answered by calculating his cardiovascular disease risk by objective calculators. We have many calculators like the Framingham score, and there is the score for the American Heart Association, American College of Cardiologists, another score that we can use to calculate the 10-year cardiovascular risk. So let's have a look at the primary prevention guidelines of the American Heart Association 2018. This is a busy slide. Now, for the primary prevention of cardiovascular disease, this depends on the age of the individual. Young individuals, we have to stress on the lifestyle modifications. Now, for individuals 20 to 40, also we have to encourage good lifestyle modifications and consider statin in cases of presence of family history of cardiovascular disease, like premature atherosclerotic cardiovascular disease, and the presence of high LDL above 160. So if these conditions apply to this individual, we can start him on statin. Now, for individuals 40 and above, we have these objective calculators. These calculators were formulated for individuals 40 and above. So we can implement these calculators to calculate the 10-year cardiovascular risk of the individual. So let's see. Now, after implementing these calculators, as we have mentioned before, like the Framingham calculator or the American Heart Association calculator, we found that the 10-year cardiovascular risk for the patient less than 5%, then the patient is at low risk for cardiovascular disease. Then lifestyle modifications will be enough. If the patient had higher risk, borderline risk, 5 to 7.5% risk for cardiovascular disease, then also we have to stress on lifestyle modification. Plus, the patient can benefit from starting him on statin, especially if there is what we call the risk enhancers. If more than one of the risk enhancers are present, we will discuss them later, then he can benefit from starting them on statin. We have to start discussing statin if there are multiple risk enhancers. Now, if the patient had intermediate risk for cardiovascular disease, 7.5 to 20%, then yes, he most likely will benefit from starting him on statin. And according to the United States Preventive Services Task Force, any individual with 10-year cardiovascular risk between 7.5 to 10%, he can benefit from starting him on statin beginning from the age of 40. So any individual with the intermediate risk for cardiovascular disease, most likely he will benefit from starting them on statin. However, some individuals, the risk decision about giving statin or not is not that much certain from our side or from the patient side. In this case, we can rely on the coronary artery calcium score. The patient had 0 score, then the patient had no urge to start him on statin. We can postpone starting him on statin unless he's diabetic or smoker. Now, if the coronary artery calcium score favors starting 1 or above, then starting statin will benefit him, and especially if the patient had more than 100 score, coronary artery calcium score, then starting statin is essential in these cases. So in the case of intermediate risk, most likely the patient will benefit from starting statin. Most individuals has to be started or have to be started on statin. However, if this decision is not certain, we can rely on the coronary artery calcium scan. Now, if the patient is at high risk for cardiovascular disease, more than 20%, then yes, it is recommended to start him on statin. So what are these risk enhancers that will favor starting our patient on statin for primary prevention of cardiovascular disease, especially in patients with borderline and intermediate risk for cardiovascular disease? The presence of family history, persistently elevated LDL above 160, presence of metabolic syndrome, chronic kidney disease, inflammatory diseases, and certain lipid biomarkers. So these risk enhancers will favor our decision towards giving a statin in patients with borderline or intermediate risk for cardiovascular disease. Now, what about starting our patient on aspirin for primary prevention of cardiovascular disease? Now, according to the United States Preventive Services Task Force, it states that every individual who has a calculated 10-year cardiovascular risk of 10% or more, and provided that he is willing to take aspirin daily for more than 10 years, and he's not at increased risk for bleeding, he will benefit from starting him on aspirin. As per the American Heart Association 2018 guidelines, starting patients on low-dose aspirin is recommended for the primary prevention of cardiovascular disease for individuals between the ages of 40 and 70, provided that they are not at increased bleeding risk. So again, this is important. If the patient is not at increased bleeding risk, so always remember that balance we have mentioned previously, benefits and harms. If there is risk for bleeding, don't give this medication for its benefits, because here in this condition the harms will outweigh benefit if the patient is at increased bleeding risk. So please always check that your patient is not at increased bleeding risk before considering starting him on aspirin for primary prevention of cardiovascular disease. However, if the individual is above the age of 70 years, it's not recommended to start him on aspirin for primary prevention of cardiovascular disease, because they found that this individual at increased risk for bleeding. So don't give them aspirin for primary prevention of cardiovascular disease. So our second patient is a 25-year-old married lady presented to the clinic for contraception counseling. She has a positive family history of breast cancer. Her mother died from breast cancer a few months ago. So how could we help this patient in this regard? Now, in addition to lifestyle modifications and risk-reducing measures in general for cancer, like adopting healthy diet, good weight management, not gaining excessive weight, encouraging breastfeeding, so we have to screen also for breast cancer. When do we start screening for breast cancer in general? There are different guidelines. According to the USPSTF, every lady should be started screening for breast cancer beginning from the age of 50 by clinical breast examination and mammography. So every lady beginning from the age of 50 should be screened for breast cancer by mammography and clinical breast examination. However, if there is positive family history of breast cancer, according to the USPSTF, we should assess her possibility of having genetic abnormalities with risk assessment tools, questionnaires, and if she was found to have high risk for genetic abnormalities, we will go for genetic testing for BRCA1, BRCA2 gene mutations. If there is positive genetic mutations for these patients, we can offer her prophylactic mastectomy or oophorectomy, or offer her starting on aromatase inhibitors, tamoxifen, raloxifene, if there is no contraindications. So these guidelines as per the USPSTF. Here in Jordan, our national recommendations is we start screening patients from the age of 40. From the age of 40 to 50, we screen every year. Then from the age of 50, we start screening every 2 years. طبعا in addition to the clinical breast examination. هلا في عنا different also recommendations. For example, we have calculators. في calculator based on the modified Gale model, by which we screen every lady or calculate the risk of or the 5-year risk of developing breast cancer for any lady beginning from the age of 35. So بنحسب على عمر ال 35 the 5-year risk for breast cancer. If it was above 1.7%, then we should start screening by clinical breast examination plus mammography beginning from the age of 35. Now, for patients with positive family history of breast cancer, we have calculators that are based on the family history of breast cancer. In these calculators, we calculate the lifetime risk of developing breast cancer. If it is above 20%, then we will go for early screening. So if the lady had a lifetime risk of developing breast cancer above 20%, so she can be screened by mammography beginning from the age of 35 or by MRI beginning from the age of 25. Other organizations recommend screening 10 years, starting screening 10 years before the family member who had breast cancer. So start screening before 10 years by either mammography إذا كان عمرها فوق 30 سنة طبعا مع clinical breast examination, or by MRI إذا كان العمر 25 years, يعني beginning from the age of 25 years. So في عنا different organizations, different recommendations. بال USPSTF we adopt إنه they adopt start screening from the age of 50 up to the age of 75, and here in Jordan we start screening from the age of 40 every year until the age of 50, then every 2 years. And if there are family history, there is family history of breast cancer, we have different calculators, and we can start screening earlier according to certain recommendations. Now, what other screening issues would you recommend for this lady? Of course, this lady is 25 years old. She's a married lady, so we have to screen her for cervical cancer. So any married lady in our community and any married lady in the childbearing age above the age of 21, she has to be screened for cervical cancer. How do we screen for cervical cancer? Usually we screen by doing pap test every 3 years until the age of 65. If the patient at this age of 65 had previously 3 negative tests, then we stop screening her. Now, you have also advised her to do screening for cervical cancer, and you have explained to her what would you perform for her at this point. But she told you that her neighbor's doctor told her that she can perform screening for cervical cancer every 5 years rather than every 3 years that you have told her about. How would you respond؟ المريضة بتحكي انتوا طلبتوا مني اعمل screening for cervical cancer ونصحتوني اعيدها كل 3 سنوات. جارتي دكتور قال لها اعمل screening for cervical cancer تقدري تعيديها كل 5 سنوات وليس كل 3 سنوات. What's the difference? How would we respond? هلا we have another option for screening for cervical cancer, which is testing for the human papillomavirus, the high-risk human papillomavirus. So by testing for the high-risk human papillomavirus, we can postpone retesting for 5 years. So the screening will be every 5 years if we implement the high-risk human papillomavirus testing with or without the cytology, the pap test. Fine. So why haven't we offered this option for our patient? Remember that our patient is 25 years old, and the option of screening the patients for high-risk human papillomavirus starts for ladies beyond the age of 30. And why is this? This is because these young ladies tend to have self-resolution of the human papillomavirus. So when they are tested, they are found more likely to have the more benign forms of the human papillomavirus. So why not to expose them to the risk of following the presence of human papillomavirus? We usually proceed for biopsy if there is high risk human papillomavirus. Why to proceed for biopsy for this invasive test? While the patient most likely will have self-resolution of that virus. So younger ladies, this is not an option for them. The only option for them is to screen them by pap test every 3 years. Now beyond the age of 30 years, ladies tend to have the more malignant forms of the human papillomavirus, and they tend to have the virus tend to persist in their cervical in their cervix. So there is no self-resolution like in younger ladies, and that's why this is applicable only for ladies above the age of 30. So below the age of 30, we can screen for cervical cancer by doing the pap test every 3 years, while beyond the age of 30, we have the option of either we can continue screening her by pap test every 3 years, or we can do the high-risk human papillomavirus testing with or without pap test every 5 years. And this is the response to our patient. Other screening tests or other preventive services we have to provide to our married lady, 25 years old. Yes, we have mentioned previously that we have to screen every patient or every individual for a hypertension. So we have to take her blood pressure beginning from the age of 3 years. So we have to screen her for hypertension. Screening her for diabetes depends on the presence or absence of risk factors for diabetes. So if she is overweight plus additional risk factor, we can consider starting her screening for diabetes. Additional testing, we have to screen her for or to assess her cardiovascular risk. We have mentioned that every individual at the age of 20 years and above, we have to assess his cardiovascular risk by doing fasting lipid profile. We've mentioned that individuals at the age of 17 to 21 years, we have to have a fasting lipid profile. So we have to have the fasting lipid profile for our lady and to assess her cardiovascular risk by this fasting lipid profile readings and by risk factor assessment. Another issue that we have to consider in this lady is the preconceptional counseling. She's at 25 years old, she's married, so she's in the childbearing age. Usually patients don't come to or don't seek medical care asking for a preconception counseling. Usually we catch our patients who came for any reason, for any service, preventive or curative service, to tell her or to ask her about her future plans for pregnancy. If she's not planning to get pregnant, like the case in our patient who came seeking for contraception counseling, we can help her by offering her the appropriate contraceptive method. However, if the patient is planning to get pregnant in the coming, let's say, 3 months, we have to do a lot for this lady. We have to check her risk factors that can increase obstetric complications in her pregnancy, like obesity, like smoking, like any chronic medical illnesses. We have to control these medical illnesses. Any medications she's taking, we have to stop them if feasible, or to replace them with medications less harmful to pregnancy. And if the patient is sure if she's planning to get pregnant within the coming 3 months, we have to start her on folic acid to lower the risk of neural tube defects of the baby, and so on. So these preconception counseling issues are very important for any lady came to you for any reason and she's married in the childbearing age. These tables are to show the cervical cancer incidence in Jordan. This study was performed by the International Agency for Research on Cancer. On 2018, the annual number of new cancer cases in Jordan is 104. 104 ladies has been diagnosed with cervical cancer in 2018. Compared with Western East Asia, for example, 5,092 cases. And look at the cumulative risk at 75 years old. قديش risk إنه المريضة على عمر 75 and below at any time point خلال هاي الفترة إنه هي young لحد عمر 75 سنة، قديش her lifetime risk خلينا نقول to get cervical cancer 0.3 in Jordan 0.3%، يعني 3 بالألف. 3 من كل 1000 ليدي بالأردن عمرهم 75 أو أقل، الريسك تبعهم إنه to get cervical cancer. Now in Jordan, according to the National Jordanian Cancer Registry, بالperiod 2008 to 2012 تقريبا عم نحكي عن 4-5 سنوات, there were 202 registered cases of cervical cancer, يعني بمعدل تقريبا 50 cases per year. And in these ladies, the most common human papillomavirus types, as usually be cervical cancer cases, the more malignant forms, the 16 and 18. This is found also in our lady. And regarding the mortality, cervical cancer is the 14th leading cause of female cancer death here in Jordan. This is very important to keep in mind. Here in Jordan, we don't have national screening program for cervical cancer على مستوى الدولة، يعني ما في عنا screening program للcervical cancer. هلا هذا الجدول بيورجينا قديش نسبة الليديز اللي كانوا بيعملوا screening for cervical cancer بال 2007 18% وبال 2012 they were 18.8%. هدول الستات اللي have ever done screening، يعني مش الستات اللي بيعملوا regular screening كل 3 سنوات. هلا السؤال إنه is it indicated إنه عنا بالأردن is it urgent إنه هلا نعمل to implement screening program للcervical cancer. عم نحكي عن 200 تقريبا حالة خلال 4 سنوات بمعدل 50 حالة بالسنة تقريبا new cases. عم نحكي عن 14th leading يعني cause of female cancer death in Jordan. The question is يعني I think we have to prioritize our or to organize our priorities. We have to يعني utilize resources تبعتنا, limited resources تبعتنا be wise manner. I'm not answering the question now. It is an open question that needs further studies بكل الأسبكتس، يعني بندرس كل الأسبكتس تبعت الموضوع. ممكن إنه في أشياء معينة نعطيها أولوية لأنها مثلا burden of suffering منها أكتر, it's more common and so on. بس طبعا هذا ما بيمنع إنه إحنا أي lady بنعرف إنه she's at high risk for cervical cancer. We have to investigate, we have to screen. So this is the situation here in Jordan. Our next patient is a 67-year-old smoker man, presented for a prescription of his antihypertensive medications. So he is a hypertensive patient, elderly, and smoker. What preventive services would you advise him to perform? number one, our patient is a smoker. So number one, we have to start with primary prevention, lifestyle modifications to help him stop smoking. So start with our patient smoking cessation advice. Number two, the patient is hypertensive, so we have to control his hypertension. نشوف إذا هو فعليا compliant على medications وعلى lifestyle modifications. If he has regular follow-up visits for his hypertension, and if he is doing regular investigations to check for hypertensive complications like retinopathy, neuropathy, nephropathy, and so on. So this is third or tertiary prevention to control his hypertension and prevent the complications from hypertension. What else for this smoker gentleman? We have mentioned that every individual has be above the age of 40 or 45 has to be screened for diabetes. So we have to check for diabetes for this gentleman. Also, we have to screen him for dyslipidemia. We have to check his fasting lipid profile. In addition, this patient is smoker, so he has multiple risk factors for cardiovascular disease. He's a smoker, he's old age, he's hypertensive. We have to check his 10-year cardiovascular risk and consider starting him on statin if he's at high risk, at borderline or intermediate high risk. We can consider also starting him on statin. Plus minus starting him on aspirin. Now he's 67 years old. Most likely, if he has no established cardiovascular disease, I personally will not start him on aspirin. As per the guidelines, USP-STF, individuals between 50 and 60 with 10-year cardiovascular risk more than 10% will benefit, and according to the AHA, individuals 40 to 70 will benefit. So 67 years old, most likely I will not start him on aspirin. However, we have to calculate his 10-year cardiovascular risk. Also, this patient is a smoker, so if he has smoking history of 30-pack year or more, we have to start him, screening him, if not already has been started on screening for lung cancer. We have to start screening at the age of 55 by low-dose spiral CT annually. Low-dose annual spiral CT beginning from the age of 55 for any smoker individual that has 30-pack year smoking, or even if he has stopped smoking, however, within the last 15 years, he is still at high risk for lung cancer if he has stopped smoking within the past 15 years. So if the patient had history of 30-pack year smoking or stopped smoking, but within the last 15 years, he has to be screened for lung cancer by annual low-dose spiral CT. Additionally, this patient is above the age of 65 and he's a smoker, so he's candidate to be screened for abdominal aortic aneurysm. How do we screen for abdominal aortic aneurysm? This is very simple test. We have to do abdominal ultrasound once beyond the age of 65 for all individuals who have ever smoked. So any history of smoking is significant. In this case, we have to screen him. This is recommendation B by the USP-STF guidelines, grade B recommendation. And if the patient had not smoked, but he has, for example, family history of abdominal aortic aneurysm that has ruptured or needed repair, so we have to consider screening them for abdominal aortic aneurysm, and this is grade C recommendation by the USP-STF. So any individual above the age of 65, any male individual above the age of 65 who has ever smoked has to be screened for abdominal aortic aneurysm by abdominal ultrasound, plus minus if he is not smoker or has not smoked in his life, but has family history of abdominal aortic aneurysm that has needed repair or has ruptured, then he's candidate. This is grade C recommendation. We have to consider screening him. So what else we have to do with our patient in addition to the lifestyle modifications, healthy diet? controlling his hypertension and preventing the complications, screening for the complications of hypertension, screening for diabetes and dyslipidemia, assessing his 10-year cardiovascular risk, considering starting him on statin, smoking cessation, counseling, screening for lung cancer and abdominal aortic aneurysm. What else we can do for our 67-year-old man or gentleman or lady? Remember that for every individual beyond the age of 65, we have to give them 3 vaccinations. Remember these 3 vaccinations. We have to give them the flu vaccine. The flu vaccine, we start giving it from the age of 6 months. But there are certain age groups, certain conditions when we stress on giving the flu vaccine, like pediatric age group, pregnant ladies, and elderly. So please, any elderly beyond the age of 65, give him flu vaccine, plus pneumococcal vaccine, plus the zoster vaccine. We give them either the live attenuated zoster vaccine, which is given as a single dose beyond the age of 60 years, or if available, we can give them the recombinant zoster vaccine. Now, the recombinant zoster vaccine is given for individuals beyond the age of 50, and it is given as 2 doses. So if the patient has, for example, immunocompromising conditions, usually we recommend giving them the recombinant zoster vaccine rather than the live attenuated vaccine, zoster vaccine. You know that zoster can leave the patient with terrible post-herpetic neuralgia. It is very incapacitating for these individuals. So it's recommended to give them a zoster vaccine. This is recommendation summary from the USPSTF about screening for abdominal aortic aneurysm. So for males aged 65 to 75, it is B recommendation, grade B recommendation, to screen them for abdominal aortic aneurysm by ultrasonography if they have ever smoked. Now, if the patient has no history of smoking, but for example he has family history of abdominal aortic aneurysm between the age of 65 to 75, it is grade C recommendation. So we have to select our patient who has to be screened in these cases. What about women and screening for abdominal aortic aneurysm? Now, for women who has no history of smoking and no family history of abdominal aortic aneurysm, it is recommendation D to screen them for. It's not necessary. There is no net benefit from screening them for abdominal aortic aneurysm, so no need to screen for abdominal aortic aneurysm. But what about a woman who has a history of smoking or who has a family history of abdominal aortic aneurysm? There is insufficient evidence to tell whether they will benefit or not. So it needs further studies to reclassify this as either B, C, or T recommendation. Now, what about screening our patient for prostate cancer? Now, as per the USPSTF guidelines, for individuals 55 to 69 years old, it is grade C recommendation. So there is a small net benefit from screening these patients for prostate cancer. Our patient is 67 years old, so he can be a candidate. However, the screening for prostate cancer is usually the test used is the PSA, prostate specific antigen. It is not specific. So it's not specific with high false positive results. Now, the patient can have, the patient can have prostate cancer. Yes, he can have prostatitis. He can have benign prostatic hypertrophy. All of these can lead to high PSA. So if we found a positive result number 2, we have to repeat the test several weeks later. And then if there is persistently high PSA, we have to do a biopsy, for example, which is invasive procedure with risks for complications like bleeding, like infection, and then we have to treat the patient with the complications like incontinence, like the risk of erectile dysfunction, for example. So keeping in mind that most patients with prostate cancer will die from other causes than prostate cancer because it's a slowly growing tumor. Why to label our patient as a cancer patient while he most likely he will die without knowing that he had cancer at all? So why to put him at that psychological harm and psychological trauma that you are cancer patient? And why to expose him for these procedures, diagnostic procedures and treatments, over treatment for these patients? So we have to, I think we have to also come back to that balance we have talked about, to weigh the benefits and harms of screening and treatment outcomes. So we have to give the patient this information and ask him to provide a informed decision whether he wants to be screened or not. We have to stress on certain individuals with a high risk, like patients with family history of prostate cancer, or patients from ethnic groups at risk for prostate cancer, like Black patients, or patients with family history of BRCA1 and BRCA2 gene mutation. They are at increased risk for prostate cancer. For these patients, so we have to individualize the condition based on, or the decision based on the conditions of our patient. Now, for patients 70 years or older, it is the recommendation. It is not recommended. The harms now outweigh the benefits, because patients 70 and above, usually there is no benefit from screening them for prostate cancer. It's a slowly growing tumor, so most likely there is the mortality will be from other causes. They will die without knowing that they had cancer at all. Now, the wife of our patient is also hypertensive, and let's say her age is also 67 years old, and the patient is asking you whether she can benefit from the same screening services that he had. Explain to her what screening services would she benefit from. Now, also his wife is hypertensive. She's 67 years old. So we have to implement all the preventive services we have mentioned previously for her husband, except for prostate cancer. Now she has peculiar investigations for women. She has to be screened for breast cancer. So we have to do clinical breast examination and mammography for her until the age of 75, where the age we can stop screening for breast cancer. Also, if she had no negative tests in the 10 years, no 3 negative tests in the past 10 years, we have to continue screening her for cervical cancer beyond the age of 65 till the age of 70 or 75. Also, being a female, she's at increased risk for osteoporosis and osteoporotic fractures. So according to the USPSTF guidelines, every woman beyond the age of 65 should be screened for osteoporosis. We have to ask DEXA scan for her. Now, do we need to screen her husband also for osteoporosis? And which female we have to screen her for osteoporosis before the age of 65? Now, beyond the age of 60 of menopause, yani postmenopausal women, and before reaching the age of 65, they have to be screened if they are at increased risk for osteoporosis. They have conditions that increase the risk for osteoporosis. For example, a lady with rheumatoid arthritis, or is taking steroids for any reason for more than 3 months, they are at increased risk for osteoporosis. So we start screening them just beyond menopause, and not waiting until the age of 65. However, if there are no specific risk factor for osteoporosis, we start screening from the age of 65, and the frequency of screening and repeating the test of DEXA scan depends on the T-score or the result of the T-score for this lady. Now, for men, there are different organizations and different recommendations about screening men for osteoporosis. According to the USPSTF, if the male patient is at increased risk for osteoporosis, for example, he has history of fracture from trivial trauma, or by imaging he had low density or by X-ray for any reason we found that his bone density is low, or for example if he had been on treatment with certain medication that that alter his bone mass density, for example androgen deprivation treatment, or if has hypoandrogenemia, so he has at increased risk for osteoporosis, and in these cases it is indicated to screen them for osteoporosis. Other organizations recommend that all male individuals, regardless of the presence of risk factors, should be started to be screened for osteoporosis beginning from the age of 75. So there are differences between the recommendations. Other recommendations we have given for her husband, they also apply for our patient. If she's a smoker, she can benefit from screening for lung cancer. Obviously, there is up till now no recommendation to screen her for abdominal aortic aneurysm. Now let's move to the pediatric population that came to the primary healthcare clinics. So they can either come for acute illnesses or they can come for routine checkup visits. So what's important elements of the routine checkup visits or the well baby, well child visits that we have to perform for these kids? Number one, we have to check for his growth parameters and plot them on the growth charts. We will see next. Also, we have to check for the vaccination status, if it is up to age or if they are delayed for the vaccination. We have to check the developmental assessment of these kids based on the developmental milestones that they are supposed to accomplish at this age. And also we have to stress on the nutritional aspect, the healthy lifestyle, healthy diet, healthy physical activity, exercise from early age, beginning from as early as possible. Before starting with patients, let's have a look on growth charts. This is an example of length for age growth chart for girls. This is adopted by the WHO. So let's have an example. Suppose we have a 10-month-old girl with 70 centimeters length. Now we mention length rather than height because children below the age of 2 years, we measure their height or their length while they are in the recumbent position. وهم نايمين ناخد الميجرمنت على مسطرة خاصة، نشوف الطول تبعهم بطريقة معينة. بعد السنتين بيكون الطفل ناخد الميجرمنت تبعه وهو واقف، فبنسميه الهايت. فاللينث فور ايج للبيبيات less than 2 years who had been measured using the recumbent position. Now let's go back to our patient, 10 months old with 70 centimeters length. This is 10 months old and this is the 70 centimeters length. They intersect here at this point. This point is between the 15th percentile and the 50th percentile. So we say that this patient's height is between the 15th and 50th percentile. This is important to notice that the patient is in between or is lying in one or between of any of these percentiles, these curves. So what does these curves represent? Now the 50th percentile represents the median of children, of the length of children at a certain age. For example, when we are talking about a child who is 1 year old, a girl who is 1 year old, this is the 50th percentile, which is at the 74 centimeters. So what does that mean? This means that 50% of normal children, normal girls at the age of 1 year had a length above 74 centimeters, and 50% of normal girls at the age of 1 year had a length below 74 centimeters. This is the median. So we had these curves that represent normal curves of normal children. So if we had a girl below the 3rd percentile, we start to monitor her over time and we start to worry, especially if the length starts to drop more and more below the curve, below the 3rd percentile. So by growth charts, we can know the normal of that child at this time point. Also, we have to monitor the projection of these growth parameters over time. For example, this is an example of weight for age chart, WH, or chart for boys from birth to 5 years. If we had a child 2 years old and his weight is, let's say, 13 kilograms, so 2 years, and this is 13, they intersect here between the 50th percentile and the 85th percentile. So he's here. So if after a year or so the same child came back with a weight of, let's say, 10 kilograms, so he was 13 kilograms, and now after 1 year he's 10 kilograms, so he's now here or even here. So we say that he has crossed 2 major percentiles, or even now 3 major percentiles. So there is something wrong. We define this case as failure to thrive. We have to check for the causes for that. So growth parameters are very important to tell us if this patient or this child is normal in this growth parameter at this time, and also for the follow-up monitoring, the projection of this growth parameter over time. This is an example of also stature for age, height for age, and weight for age percentiles for boys till the age of 20 years. This is adopted by the CDC. And also we have the same for girls. So we always rely on growth percentiles when we are talking about growth parameters in children. It's not enough to say the child is 2 years old and he has a weight of 14 kilograms. This is not enough. We have to say that he is on such and such percentiles for height, weight, and head circumference. Now let's start with the first baby, 5-day-old baby, presented for a well baby clinic, presented for the neonatal screening. So what would you like to perform for him at this visit? As routine part of the neonatal screening, we here in Jordan give all neonates during the first month of life vaccination against tuberculosis. So we give him BCG vaccine within the first month of life. Another part of the neonatal screening is the heel prick test. By the heel prick test, we screen for multiple anomalies or abnormalities. Like here in Jordan, we screen for 3 things: for congenital hypothyroidism by TSH, phenylketonuria, and G6PD deficiency. So here in Jordan, we screen for these 3 conditions by the heel prick test. This is performed after the first 48 hours of life, ideally on day 5. Can be postponed for a few days. However, ideally it has to be performed during after the first 48 hours and during the first week of life. This is another test that has to be performed during the early neonatal period. That is hearing assessment, auditory screening, official hearing assessment to check for any congenital hearing abnormalities. important thing to be done, however, this is done usually during the hospitalization before discharge, is to screen for critical congenital heart disease using pulse oximetry. This is recommended by the American Academy of Pediatrics and the American Heart Association. And this is because congenital heart disease is the most common congenital disorder بالنيوبورنز. And the critical congenital heart disease اللي هو بيعرفوه إنه congenital heart disease that needs to be repaired بالfirst year of life. It accounts for almost 25% of all congenital heart diseases. فلما يكون في delay بالdiagnosis and referral for repair, the risk of morbidity and mortality usually will increase. المشكلة إنه yes, usually البيبيات اللي بيكون في عندهم critical congenital heart disease, there will be symptoms and signs بالphysical examination during hospitalization. However, up to 30% of infants with critical congenital heart disease appear normal on routine exam during the birth hospitalization. Cyanosis may not be apparent بهدول الأطفال. أو أوقات cyanosis لما يكون في oxygen saturation above 80% cannot be يعني ما بيكون apparent، وخاصة بالأطفال deeply pigmented، الأطفال color of the skin is dark عندهم. So high importance of screening by the pulse oximetry. هلا usually it's performed after the first 24 hours of life. So if إذا كان لأنه بالخلال أول 24 ساعة transition between الانتريتيران والإكستريتيران life بيصاحبها hypoxia. فيفضل as much as يعني as late as possible before discharge إنه ينعمل له. هلا إذا البيبي يروح قبل يعني قبل 24 قبل first 24 hours وأجى على العيادة، يفضل نرجع نعمل له إياها البلس oximetry. Usually it's performed from the right hand and either foot، يعني right or left foot، عشان نشوف البريدكتال والبوستدكتال oxygen saturation. فهذا بيعطينا hint على possibility إذا كان في لا سمح الله abnormality، بيعطينا hint على possibility of critical congenital heart disease. plus في أوقات ما بيكون في critical congenital heart disease، ممكن يكون مثلا في respiratory distress syndrome، ممكن يكون في pneumonia، ممكن يكون في sepsis، ممكن so في other causes that can be detected by this pulse oximetry testing. Another issue that can be done during hospitalization before the hospital discharge and is recommended by the American Academy of Pediatrics is screening for neonatal hyperbilirubinemia. Now, for the American Academy of Pediatrics, the anticipated benefits of the neonatal screening for hyperbilirubinemia is to early detect البيبيز اللي عندهم يعني hyperbilirubinemia، وبالتالي to prevent acute bilirubin encephalopathy by either phototherapy or exchange transfusion حسب indication. هلا بالنسبة لليو اس بي اس تي اف والامريكان اكاديمي of family physicians, they don't till now they don't agree with this recommendation. According to them, there is insufficient evidence to warrant this universal screening for neonatal hyperbilirubinemia. So it can be done before discharge to screen for hyperbilirubinemia and to prevent acute bilirubin encephalopathy. So we have mentioned that the BCG vaccine is given for all neonates during the first month of life here in Jordan. This is the national vaccination program in Jordan. As we can see, at the next vaccine following the BCG vaccine will be at the end of the second, third, and fourth months. Babies turn back at these times for giving them these 7 vaccines: the diphtheria, tetanus, pertussis, Haemophilus influenza, hepatitis B virus, poliovirus vaccine, and rotavirus vaccine. So these vaccines are given at the beginning of the 3rd, 4th, and 5th months of life. Regarding the poliovirus vaccine, the first dose should be the injectable form of the vaccine to lower the risk of developing polio or vaccine-associated polio paralysis. So the second and third, the second dose usually is a combination from the oral and injectable forms, and the following vaccines usually are given in here in Jordan by the oral poliovirus vaccine. So these vaccines are given at the 2nd, 3rd, and the end of the 4th month of life. Then the following vaccine should be given at the 9 months of life, which is the measles vaccine in combination with the OPV, a booster dose of the oral poliovirus vaccine. Measles and OPV are given at 9 months of age, and in conjunction with these two vaccines, we give usually vitamin A. Why? Because vitamin A was found to enhance the body immune response to measles vaccine. So at first birthday of life, babies usually receive the measles, mumps, rubella vaccine, which is repeated at the 18 months of life. So at 18 months, they receive the MMR vaccine and a booster dose from the OPV vaccine and a booster dose from the DTP, diphtheria, tetanus, pertussis, and this time they receive the whole virus, the whole cell vaccine from pertussis rather than the acellular vaccine. So at 18 months of life, the DTP, diphtheria, tetanus, pertussis, the MMR booster dose and booster dose from the oral poliovirus vaccine in conjunction with vitamin A again. So these are the routine vaccines that are given during early childhood. They are followed by coming vaccines. For example, at the age of 6 years, all students entering the 1st grade are given the tetanus diphtheria vaccine, and at the 10th grade, at 16 years of age, they also receive a booster from the tetanus diphtheria vaccines. Another baby came to you at the age of 9 months. So what elements of the routine checkup that you have to do for this baby? Number one, we have these 4 major aspects of the well baby visit: growth, taking his growth parameters and plotting them on the growth chart to monitor his growth. Number 2, developmental assessment. Number 3, we have to check for his diet, because usually weaning is recommended after completing 6 months of life. So at this visit we have to check what type of diet the baby is having. Usually we recommend or encourage mothers to give their kids a diet rich in iron. Now, if the iron is not sufficient in the diet, then the baby will develop iron deficiency anemia, because maternal stores of iron usually end at 5 or 6 months of age. So if the diet is deficient in iron, there will be iron deficiency anemia. So specifically at this visit between the ages of 9 months and 1 year, here in Jordan, usually we screen for iron deficiency anemia, where we ask for hemoglobin or CBC to check for this condition. As part of the vaccination, we have mentioned that kids at this age usually receive measles vaccine, OPV booster dose, and in addition, vitamin A dose is given as well. So what we are expecting from our 9-month-old infant to perform at this age: usually at this age, all babies should sit alone without support. If any baby at the age of 9 months not sitting alone without support, we should examine deeply neurological assessment to rule out hypotonia, for example, and we may need further investigations. Also at this age, they usually start to pull stand on furniture, and sometimes they start to move also while holding on furnitures. Regarding the fine motor assessment, they usually transfer objects at this age from hand to hand, and they start to have the pincer grasp. بيمسكوا الأشياء بالthumb and the index fingers. And regarding the social aspect of their growth, usually they start to have separation anxiety from their parents and to have stranger phobia. ببلش يخاف من الأشخاص الغرباء. And regarding the language, they usually at this age use their fingers to point to things that they want and respond to sound of name. لما حدا ينادي اسمهم بينتبهوا على طول and start to wave bye-bye, start to understand peekaboo, play, and so on. So babies at the age of 9 months are expected to sit alone without support, to pull up, to stand, to grab finger foods with pincer grasp, both index and thumb fingers, and they start to have separation anxiety and social phobia. Also, they, as part of their social development, they respond to sound of name and waves bye-bye. We have another baby at the age of 18 months presented for Well Baby Clinic. So as part of routine assessment, we have to check for growth parameters, vaccinations we have mentioned previously. In addition, at this age, we have specific screening, which is screening for autism. It is recommended by the American Academy of Pediatrics to fill certain questionnaires to rule out autism. These questionnaires are usually filled by the families, by the parents, and the same questionnaires should be repeated at the age of 24 months to rule out autism. In addition, we have the issues of teething. احنا بالعاده بنعرف الاسنان usually الاطفال على عمر السنه بيكونوا بلشوا يطلعوا الاسنان not later than 18 months to start teething. So بهذا العمر على الاغلب في عنا كم من سن. We have to take care of them, good hygiene to prevent dental caries. يفضل نعمل fluoride varnish على الأسنان by the dentist to prevent dental caries. In addition, إذا كانت الاريا اللي عايشين فيها deficient في fluoride, we have to give the child fluoride supplements. In addition للdevelopmental assessment بهذا العمر مهم كتير نركز على الwalking. بهذا العمر الأطفال مفروض كل الأطفال بيمشوا. إذا في طفل ما بيمشي لهذا العمر معناته في عنده delay. This is red flag. We have to make further investigations. In addition للlanguage, usually بهذا العمر الأطفال بيحكوا 6 كلمات، 5 ل 6 كلمات المينيمم. بالعادة بين 5 كلمات و20 كلمة بهذا العمر بيحكوا. الناس بالdevelopmental assessment, they have 5 to 20 words. They build a tower of 3 cubes. ببلشوا يركضوا. In addition للمشي ببلشوا يركضوا، ببلشوا يمسكوا السبون وياكلوا مثل الكبار and so on. طفل آخر عمره 3 سنوات جاي for will baby visit. So in addition to the routine care, we have growth parameters, checking that vaccination. طبعا ما في vaccine على هذا العمر، بس نتأكد إنه vaccination تبعه up to age. الدايت تبعه، developmental assessment. We have also at this age to stress on certain screening. For example, we have mentioned previously that we have to screen all children at the age of 3 years. Start screening for hypertension by annual measurement of blood pressure. In addition, at this age, we start to have a visual assessment for toddlers between the ages of 3 and 5 years. We have to check for a visual assessment for visual acuity and refractive errors. So these charts are designed for toddler examination for the visual acuity. In addition, as part of visual assessment, we have to rule out strabismus. We have more than one test to screen for strabismus. We have this simple corneal light reflex. نوقف بعيد شوي عن الطفل، بنكون حاملين تورش وبنفتح التورش، مفروض يكون الريفلكس تبع اللايت equal ب both eyes. This is normal corneal reflex. هون بنلاحظ إنه اللايت reflex على الكورنيا is lateral للpupils. هون centrally بالpupils at equal distances. هون it is lateral to the pupils. So we have problem in this eye, strabismus, esotropia. While هنا الlight corneal reflex جاي medial to the pupils. So in this case we have exotropia. This is another test by which we can screen for occult or latent strabismus. إذا ملاحظ هون الطفل هذا apparently ما في عنده مشكلة، ما عنده strabismus. His eyes looks normal. هلا في عندي تيست بنسميه cover، وفي تيست اللي هو هذا التيست بنسميه cover and cover test. هدول screen for this latent strabismus. هلا مفروض لما نحط الكفر مفروض انه ما تتحرك العين. هلا اذا تحركت معناته في عندنا strabismus، فاحنا بنلاحظها لما نشيل الكفر على طول بصير في، احنا بنشيل الكفر رابيدلي على طول بصير في رابيد ريتيرن للاي، بترجع الاي للبوزيشن الطبيعي اللي كانت عليه، بس احنا بنلاحظ هاي الحركة فعليا. فهاي تعطينا indication ان طفل may have latent strabismus, we have to refer him to an ophthalmologist. This is the last case in our discussion. A 6-year-old child came for well-child visit. He's attending school the next month. So remember the vaccines we have mentioned previously for kids at the age of 6 years. We have to give them the OPV vaccine and tetanus diphtheria, TD vaccination. Also, as part of a growth assessment of this child, we have to assess growth parameters and plot them in the growth chart. And very importantly, we have to check for obesity. We have to start screening at this age for obesity. So we have to calculate his body mass index and plot body mass index on the body mass index chart designed for boys as he's boy. So if the body mass index was below the 5th percentile, so the child is underweight. If it is between the 5th and 85th percentile, so he has normal weight. Between 85th and 95th percentiles, overweight, and any body mass index above the 95th percentiles means obesity. So we have to screen all children beginning at the age of 6 years for obesity. In addition, we have to check for the other growth parameters and to check for visual assessment if not performed previously at the age of 3 to 5 years. And by this, we have finished our discussion today. Hope that everything was clear, and for further details and further clarifications, please visit the full lecture at tiny.cc/prevention. Assalamu alaikum.